Hello, and welcome back to another episode of More Than Milestones. I am so excited to be here today with Becki Westover, who is a certified orthotist with Bloom Kids and has over 20 years of experience in public and private practice. We are going to be digging into all things helmets, flattening on the skull, all of it. But I would love to first turn it over to you, Becki, and just tell us a little bit about you, what you do, where you are, where people can find you if they want more information, that sort of thing.
Yeah, so I'm a Canadian board certified orthotist working west side of Toronto. I have a master's in rehabilitation and specialization courses from a few different companies and a few different sources, specifically on the infant cranium and helmet therapy. People can find me on Instagram. My handle is Becki at Bloom. And I also have a website, www.bloomkidsorthotics.com.
And we will put links to all of that in the episode notes so that they can find you. So starting from the top, because I think that this conversation, there's quite a bit of controversy around helmets, I would say. Like some people feel very strongly. You get the cosmetic conversation, which we'll talk about. But can you just start by kind of explaining what actually is a certified orthotist?
So, in a broad sense, a certified orthotist can treat any area of the body by assessing and fabricating a custom device, usually out of plastic, metal, or leather. And we find solutions for pain relief, healing, mobility, prevention of injury, and deformity. So, specific to helmets, we specialize in figuring out where the flatness is, how quickly it's going to correct, and how we can kind of redirect new growth of the cranium into those flattened areas in a very passive way.
Yeah. We're going to get into in just a minute kind of like the most common flattening that a lot of parents see in their little ones and end up being referred for helmets and that sort of thing. A lot of the conversations I hear are parents who are hesitant about helmets because is it going to be heavy? Is it going to be hot? Is it going to hold up their milestones? And I think that it can be a common misconception that, it's this big bulky thing and it's adding all this weight to their head. But can you just explain briefly like the materials that you use and what you mean by how passive it is?
Yeah, so commonly these devices are made out of a high temperature thermoplastic. More recently, they're 3D printed, so they're uber light because the technology is changing very quickly. And there's a
Wow.
layer of foam padding, which allows for some softness. Now, they are hot, but babies all over the world in all sorts of climates can wear a helmet easily with proper parent education. So to say that they're not hot would be a lie, but can a baby healthily wear a helmet without overheating? Absolutely. Okay.
Awesome.
Did I
Okay.
answer the second part of your
Yeah,
question?
yeah.
Okay.
Absolutely, absolutely. Okay, so let's get into kind of the common flattening that we see, and we'll talk a little bit about why there's a rise, because that's another piece of the conversation. Especially I feel from people who are kind of anti-helmet is like, well, why we didn't have helmets? Why what does it matter? Why is there such a rise in flattening? So in my experience, I see plagiocephaly for sure the most, and oftentimes it is very closely tied. Well, I want to say all of the time. If there's a plagiocephaly, there is typically a torticollis, right? And for me, it's always kind of like the what came first, the chicken or the egg
Mm.
conversation. Like, did the torticollis cause the plagiocephaly or vice versa? But can you explain to us a little bit about plagiocephaly in general and just give us an overview of what are the common flattening areas that parents might see that would prompt a consultation for a helmet?
Well, so I would be the same. I think the most common type is plagiocephaly. Some would say that asymmetrical brachycephaly, which is basically the widened head shape, but more on on an angle. So kind of like a plagiocephaly, just in a slightly different spot is more common. Brachycephaly is straight across the back where there's perfect symmetry of the head. It's just super wide and super short. Scaphocephaly is a very elongated head shape where the head is very narrow and from the side profile it's very, very long. Plagiocephaly is like almost like a 45. It's either on the right or it's on the left, and it's usually, around 45 degrees, I guess, from midline.
And in terms of risk factors for developing those things, kind of understanding that it happens in utero. It can also happen once they're here. I'm going to just cover super quickly what even is torticollis and what plagiocephaly is, because I think it's important in understanding kind of what next steps could or should be for parents, right? So torticollis, for listeners, in layman's terms, if you take your head and you touch your right ear towards your right shoulder and keep your hand on the right side of your neck and then look up towards the left, that muscle that bulges into your hand is called the sternocleidomastoid muscle. And that in torticollis is the primary muscle involved, and it's tightened up. So you can imagine if you're in that position, especially as a newborn or in utero, if you're kind of wedged there, right? And you don't really have, like, if you think about your newborn, you don't really have, they're not moving a ton, right? They're really relying on us for positioning. They're relying on us for moving from point A to point B, really just starting to look around. If you think about being in that position for a prolonged period, you can imagine that the back of the skull, which is super malleable and soft in those first 6 months, can really just kind of flatten up. And then what I see in therapy, and I'm sure you could speak to this too, what I see in therapy is now you have this ridge, right? So baby is already struggling to learn, to move. They're working through all of those, quote unquote, normal milestones. But now they have this big ridge on their skull that they have to get up and over to be able to get their head into midline or turn to the other side. So typically what we see with torticollis is that there can be a sequelae of events, and torticollis is so easily managed, but the earlier you start, the faster and the better results that you'll see, because torticollis can be a royal pain in the butt. It comes back when baby's sick, when they're going through a growth spurt, when they're all of those things. And so when you have that flattening, when positioning alone isn't helping, that is really where I tend to refer out for a helmet, because it's hard. It's hard for them to work through those milestones with all the stars aligned, let alone when there's that flattening there. And so where that kind of ties in for me in terms of the conversation, in terms of plagiocephaly, but also in terms of like brachiocephaly, is with kind of like the overall rise in the use of baby containers. And so when we had the Back to Sleep campaign, which I'm not knocking, absolutely important, tummy time then became a thing, which I think is why a lot of times grandparents or older generations will be like, we didn't do tummy time and you guys were fine. Why is tummy time even a thing now? But it's a thing because my mom is a pediatric physical therapist, and she's like, you slept on your belly. I laid you down in that crib, and the minute you woke up, you started lifting your head and you were working through it. And I think that inadvertently with the Back to Sleep campaign, a lot of parents became fearful of putting their baby on their belly. And so the movement and tummy time, really formal tummy time recommendations, came around that time to kind of combat the explosion of the container industry, because they definitely saw an opportunity, right? Parents were fearful of putting baby on their belly. So they're like, here, let me give you 30 devices that you can just move baby from their back to their back, to their back, to their car seat, to their back. And so when it comes to torticollis and plagiocephaly, and we'll touch on kind of how important treatment of the underlying cause, if there is one, along with helmet therapy, how important that is. But if you think about even going back into that position I described before of torticollis, where you're tilted to one side and rotated towards the other, if you are in now an anti-gravity container, say, and you can't lift your head up, you can't look in the other direction, you're just constantly reinforcing that flattening like a pumpkin growing into the ground with nowhere else to grow. So I would love to hear your thoughts. I know we had also talked a little bit before we hopped on here about the rise in IVF births, which I have never made that connection about twin A and twin B. So I would love if you could share that, because I think that's very, very interesting and very, very relevant.
For sure. I was going to back up and just add two things while you were chatting, I thought of. The first one was we were talking a lot about torticollis, but sometimes there can be asymmetry tightness left over from being in utero, in the spine, in the hips, and maybe not necessarily. And I know you know this, but I wanted to highlight that
No,
The baby
absolutely.
may
Go
not
for it.
have congenital torticollis. They may just have weakness or tightness or asymmetry in the body that's contributing to that constant head position, right? So obviously the job of the pediatric physical therapist is to find where that is and work through it. The other thing I wanted to tell you, and you probably know this too, but the back to sleep campaign was actually, when it first came out, was supposed to read back to sleep, tummy to play. And we forgot about the tummy to play, right? Because and I understand as humans why, because the back to sleep program was so effective at reducing infant mortality that we were just so like proud that we could save these babies' lives. And then we just kind of, I guess we just kind of forgot about the tummy to play. Right? So it was in there. I think they knew that the baby would need that, but the focus, as you described, became on, keeping their airway clear, get them on their back, and
Yeah.
let's save lives. And any parent is going to choose to save life over flathead, obviously. But I think that's interesting to know and good for parents to hear that it was actually supposed to be back to sleep, tummy to play.
Yeah.
Now, sorry, to the question you were talking about IVF, twin A, twin B. So usually, if I'm treating twins, it's 95% of the time it's twin A, and it's usually because twin A has twin B's body weight on top. And so they're kind of pushing them down low into the pelvis where a lot of more of those hard bony structures, the bony pelvis. And so they have less room to move their little neck and their little body around. And so they kind of like get stuck in that position as they go through their growth and development in utero because they're twins pushing down on top. And then sometimes, not always, but it is common for twin B, whose head is usually, if they're breech, oftentimes they are breech, but if their head is kind of up, it's up in the rib cage. And as you know, the rib cage is shaped a little bit elongated. And so twin B often presents with a scaphocephalic head shape, and twin A often presents with a plagiocephaly style head shape. So, and again, it's not always, but I can usually tell which one's twin A and twin B without being told.
So
Isn't that
interesting.
crazy?
That is
Yeah.
so interesting. Wow. And
Yeah.
I would say, I guess my question would be, is that in your experience, multiples in general or specific to the rise in IVF having a rise in multiple births?
Well, I think multiple births alone, IVF or not, what I just described is true. But I think in the context of the discussion on the rise in general of infant flathead, I think because we're using IVF and I don't know a lot about IVF, but what I do know is that they'll often implant multiples, hoping that at least one will catch, and oftentimes two or three will develop and become viable. So I think the increase in been an increase in multiple births, and just by default, twins are usually born prematurely or earlier, and their skulls are softer. So I just think
Yeah.
naturally that's why we've seen an overall rise in cranial deformation.
Yeah. Super interesting. So I would love to kind of just quickly touch on the time frames in which parents can kind of keep an eye. What should they be keeping an eye on? What is our window? So like here, for example, really that like 4 to 6 months is kind of, in my experience, the sweet spot where in the first 4 months of life, we can really be intentional about positioning and see changes, especially because for the most part, baby is really, again, still relying on us for mobility. So if we put them on their side, we can position them in a way that keeps them there and hopefully we can see changes. In my experience, orthotists really seem to love that 4 to 6 month window of like getting in there, seeing results and seeing them quickly and hopefully not needing multiple helmets, not needing, long course of treatment. So I would love if you could kind of share with us and with parents your experience on those time frames and how the skull really ossifies and becomes less and less malleable.
Yeah, I would agree with the what you're kind of talking about, that 4 to 6 months. So I would say, pretty much any baby, unless it's a very unique presentation, if they're measuring in severity kind of mild to moderate, you can wait until 6 months and you can try the repositioning, the tummy time, the physiotherapy, because you still have plenty of time to correct that head shape when you start a little bit later because you have less to correct, right? So you need less growth. And then the argument that a lot of people have is, well, why wouldn't we just get it done sooner? And the rebuttal is well, if you started a mild head shape at 4 months, they'd be done in 4 weeks, and then the risk of it going backwards is quite high. So
Oh,
timing wise, a mild to moderate head shape usually is better started at 6 months. A more severe head shape is usually better started closer to four. But the problem is that most people don't know what it is. Is it mild or is it severe? And so that's where those referrals for having a cranial orthotist take a look at the head shape and determine the severity and then perhaps a treatment plan based on the severity.
yeah. And can you explain a little bit about what that process looks like? Like, so, okay, the family comes to you. They know that obviously there's some flattening, but they don't really know if it's mild, if it's moderate. What is kind of your process that a family could expect navigating that?
Yeah, so a lot of people place a lot of, I guess, rigor in the digital 3D scan, which is a fantastic tool for monitoring change, whether it be helmet or therapy, but there are limitations to that 3D scan. So it's a great tool, but I like to do the objective scan, 3D scan, with a more qualitative or subjective assessment. And there is an evidence based severity scale that we can use. And and I find parents actually like it better because it uses regular words that they understand, like eye asymmetry or cheek asymmetry or, sloping of the top of the cranium. Like they can understand that, whereas the numbers don't really mean a whole lot unless you take the time to explain it to them,
Yeah.
which I do. But a family could expect to be assessed for history. Their main concern, a lot of times families see specific things that I see, but they're not really worried about it. Obviously, figuring out what their goals are and then doing the objective and subjective analysis, and then kind of giving them, different treatment options. If it's severe head shape, obviously, it's like, I really think this is something that you need to consider. We're looking at growth and development of the eye, fit and function of sporting equipment, helmets later in life. If there's jaw malalignment in severe cases, are looking at TMJ, arthritis later in life. Like that's not meant to scare people. And I wouldn't say that a lot of kiddos, we are worried about that. But if it's there, we need to talk about it. More milder cases, they can be a little bit more of a cosmetic choice where there's a bit of a gray area. Maybe the choice would be, why don't you do physio for 6 more weeks? Come back. Let's have another look and see if they got better. And if they didn't get better or they got worse, well, then the parents then have really good knowledge to make the best decision for their baby. And if
Yeah.
they get better, then, maybe it's good enough that they don't need a helmet. And then it becomes a purely cosmetic choice,
Yeah.
right? So that's the purpose of the evaluation is kind of figure out the severity, educate the parent, and if there is options to go a less kind of invasive route as a helmet, like therapy with yourself, then we give them that option and have them come back.
Yeah. And I would love to just circle back to that, the cosmetic piece, because that is something that I feel like helmet naysayers use all the time. And I think what you said is so important and like needs to be driven home is that yes, of course, there is a cosmetic piece, especially in milder cases, but there is truly so many other things that can be impacted by significant or, severe flattening on the skull, like things like being able to put a baseball helmet on or get a ski helmet to fit you correctly. I think a lot of people don't think about those sorts of things. And I've worked with children who have like depth perception struggles because of serious eye shifts, and I think that, like you said, it's not meant to scare anyone, but I feel like especially when insurances use the "it's just cosmetic" thing, it's so easy for parents to feel kind of inadvertently persuaded that, like, oh, it really is no big deal. But I think it's important to understand that having at least the assessment done, which most times is free or very low cost, at least around here, many of the places, so that you have kind of the full picture and you can make an informed decision based on how your little one is presenting, not how your insurance feels, not how your brother's nephew experience things, because it
Mhm.
really is so individualized. I just wanted to, the cosmetic thing makes me crazy. And another piece of it too, and I hate to say this, but like children and people can be cruel, And if there is, anyway, my point is, I hope that you can hear the cosmetic piece and just understand that, and this is for everybody out there, that there is so much more to it, and the best way to make a truly informed decision is to have the full picture for your kiddo and your family, and then kind of go from there. Um, but I would love to kind of pivot to hear your thoughts about what the research actually says about cranial helmets, the effectiveness or not, or, yeah.
Yeah. So that again, that's another I think that's where some of the root of the discrepancy in what the pediatricians are recommending versus what the orthotist might recommend. Because the truth of it is that with respect to the literature and the research, we really are in the infancy of studying this. We know a lot, but with the Back to Sleep program coming out in 95, it took 10 years for everybody to actually do full back sleeping all the time. So we've really only had about 20 years of research, which sounds like a lot, but in the research world, that's not a lot of time. So the evidence, I mean, there's very clear evidence on the use of cranial helmets from multiple researchers. There is one article that, and every orthotist or cranial therapy person involved in cranial therapy knows what I'm talking about. It's from 2014 by a group in the Netherlands who basically said that helmets don't work. The head will round out on its own by the time they're 2 years old. And so that evidence is there. And that's what a lot of people are referring to is that one study. And the reason why that study has so much rigor is because it actually was an RCT, which, as you know, is the highest level of evidence, whereas a lot of the other research might be more lower in terms of its rigor. It might be like a level two or like a case study. So this randomized control style, when you look at it and you critically appraise it, it actually has quite a few flaws. And no one's going to know that unless they do what I do, which is heads 24/7 and they go through and they read it, right? But a lot of the position statements, for sure here in Canada, the position statement is built around that one study because it was such a high level of evidence. So, I mean, I have a whole list of articles that I could provide. We could link to it if you need to, but the evidence is really, really clear aside from that one. But I think it's important to just highlight the fact that there's just this one study that holds so much in the medical community because they love a good randomized control trial. And it's really hard to blind a parent as to whether their baby has a head or not in a study, right? Like they either do or they don't. It's not like taking a sugar pill or a white pill with the medication
Yeah.
in. So it's a very difficult thing to do. And somehow this group was able to randomize it quite well. But
Now, I would love to, I'm sorry. Is there anything else you wanted to say on that
no,
note?
I guess I'm just trying to answer your question better, without starting to list all the articles.
Yeah, yeah, yeah. No, I think that's super helpful. And I also think the important thing to understand about pediatrics in general is that it is a very challenging population to really get strong, strong research in just by
Mhm.
nature. But I'm also really curious. So, again, this is just my experience. Many of the cranial orthotists that I've worked with won't actually helmet after a year because they feel that there will not be true changes, that the skull has ossified so much at that point that there's not going to be enough of an impact to make it worth it. So it's interesting to me that Netherlands study said by age 2. Like what are your thoughts on kind of that timeline?
Yeah, that's a good question. I think that they were basically saying that helmet or no helmet. I'm not so sure that the babies that wore the helmets in this study, I mean, they must have been wearing the helmets. But yeah, I don't know. The helmets in this study that I'm talking about were very poorly fit and they were by
Yeah.
multiple different suppliers. So that's like one of the
Wow.
problems.
And
I
now
think
will
that
you helmet a child after a year? Like, what is your kind of like, "We're done here"?
definitely 18 months because that's when the fontanelle is closed. Um, I do helmet babies after 1 year, but I'm very, very honest and careful that I tell the family, I have treated many patients after 12 months old, but the outcomes can vary. We may do this and get literally nothing, or we may do this and have a nice outcome, not a perfect outcome, but you know, could we get them from severe into moderate? Probably. Are we going to get them from severe to normal? Absolutely not. So I think it's my job to say, I'm willing to try. Here's what you can expect. Just know that if we go through with this, there is a possibility. And it's very rare that I do this after 12 months and there's nothing. There's usually some correction. And
Wow.
I tell them that. I said, but you got to be really compliant and you have to wear this helmet 23 hours a day. There's no cheating in this instance with the wearing schedule.
Yeah.
And I've seen some decent outcomes, and parents usually
Wow.
tell me that they're happy at the end of treatment, and they're glad that they did it.
It's
But you
amazing.
just have to be honest about what to expect.
Yeah, yeah.
Yeah.
Wow. Okay. I We talked about the evaluation and recommendation process. One thing I really wanted to make sure that we just touch on in this episode in general is the thing that I think often scares parents, is in terms of so here, and I'll have you speak to this too. But here, typically, before a child even goes to the cranial orthotist, they are referred to neurosurgery, and the purpose of that is to rule out something that can feel very scary. And of course, anytime a parent hears that their child is going to see a doctor like that, I'm sure that that feeling is unnerving. So, can you talk to us a little bit about why that is, what they're ruling out, and, kind of the importance of that? So, to take some of the fear out of it, I guess.
So what they're doing is they're ruling out craniosynostosis, which is premature closure of the sutures in the skull plates or in the bones of the head. Or sorry, in the sutures holding those plates together that are very mobile. It's extremely rare, but if there is, a partial closure or a full closure of one of those sutures, it does need to be operated on. And the reason they do it so early now compared to, well, again, I don't know, maybe 5 years ago, 10 years ago in your region, but the reason they do it so early is because if it is in fact a partial or a full suture closure, they can do a surgery that is very minimally invasive before 4 to 6 months. It depends on where you are. Some will do it before six, most will do it before four. Sick kids here in Toronto will only do it before 4 months of age. And it's minimal blood loss, quick, like in and out of the hospital very quickly. Versus if they don't make that referral before the 4 to 6 months, they make it like 7 months old, then the baby has to have, significant surgery, lots of blood loss. The likelihood of it actually being craniosynostosis is very, 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 very low. The incidence is very low. In my 20-year career, I've probably treated like one per year or less. So it's very, very rare that this happens. But if it does, it needs to be addressed. And so the pediatricians, they're just caring humans who recognize that they don't have the skill set to know, is this plagio or is this cranio? I don't want to take a chance, so I'm just going to send you. That's all they're doing. They're
Totally.
actually doing a really good job with
Absolutely.
what they have, right?
Yeah.
So I would just say that that's just a caring pediatrician, right?
Love that. I love that. Yeah, I think that's really important for parents to hear because I know I know that that can feel very scary, and even with patients that I've seen, they're like, "Why are we getting referred to neurosurgery?" But it really most of the time, it is typically exactly like you said, just the doctor making sure that they're covering all their bases and getting the child the right care that they need.
Yeah. And
Okay.
neurosurgery sorry, I was just gonna say, like,
No, go ahead.
I know the group often they'll walk in and walk out. They'll be like, "It's not cranial," and walk out, like,
Yeah,
without even taking an X-ray. It's like due diligence to the nth degree because we're talking about an infant, right?
totally. As a mom, I know how important it is to stay energized and hydrated, especially when juggling work, kids, and everything in between. For me, that's where Element comes in. Most hydration drinks are packed with sugar or artificial ingredients, but Element is different. It's an electrolyte drink mix that has everything you need in the perfect portions: sodium, potassium, and magnesium without any of the junk. It helps me feel clear headed, hydrated, and ready to tackle my day. I have packets shoved everywhere, so I never have to go without, whether it's after a workout, after chasing the kids around, or just because it's delicious. It's been such a simple way to support my energy and hydration. And the best part? Element is offering my listeners a free sample pack with any purchase, which is 2 of each of their signature flavors: raspberry salt, watermelon salt, orange salt, and citrus salt. Just check out the link in the episode notes below to get started. And if you're not sure which flavor to snag initially, trust me on these next 2 words: lemonade salt. It is a game changer. Truly, staying hydrated doesn't have to be complicated. Check out Element and see the difference it will make in your daily routine today. So, can you just briefly, and I know that Starband is your thing. Can you just give us an overview of, if a helmet is going to be prescribed, what kind of are parents' common options, and maybe like the pros and cons in your opinion of Starband versus Docband, or regionally vice versa? Kind of your thoughts on that.
Yeah, so I think that both Starband and DocBand are 2 large companies in the US that provide cranial helmets for orthotists and occupational therapists to use to treat infant plagiocephaly and craniosynostosis. I don't know about DocBand though. I have a bias. I have a relationship with Starband, and in Canada, we don't have access to DocBand, so
Oh,
I've never worked with one before. So I do think it's important to know that. But from my virtual care caseload, I do have a little bit of experience in the parents' experience using the 2 different devices. But I would say one of the biggest differences, whether you go to one or the other, is regionally, usually only Starband is available, or in your state, only DocBand is available. So that's just where people go. Traditionally, star bands are more commonly fit by certified orthotists, and doc bands traditionally are more commonly fit by occupational therapists. So that there's a big difference there in terms of who's fitting the helmet usually and their skill set. So a certified orthotist, it's kind of more their niche to work with physical materials, high temperature thermoplastics, understanding kind of the mechanics behind all of that. Whereas with occupational therapy, at least here in Canada, they get very little, like maybe a week of using, low temperature thermoplastics. So they don't have that knowledge that I feel is important. So that would be the one of the biggest difference. Starband is also known for doing kind of one helmet, and if a second helmet is required due to a very severe case, they'll often do a second helmet for free because they believe
wow.
so strongly. Yeah, they believe so strongly that it should be one helmet, and they've designed their device for it to be one helmet. But I have had a handful of cases that were very severe, complex, significant torticollis that just wouldn't manage. The family really struggled to straighten out the body. And so we have gotten second ones covered through them.
Wow. That's amazing.
Doc Band is more known for doing multiple helmets. Perhaps it has to do with the way that they are fabricated. Maybe they have a little bit less foam. I know they're known for being maybe a little bit more low profile. And so, with less foam and being more low profile, you have less adjustability to be able to grind into the foam as the baby's head shape is increasing. And I don't know this. This is a guess because I've never used one. But that's where I think the kind of the second helmet is coming from, is that they just don't have enough space within the helmet to safely treat the baby. So those would probably be the 2 biggest differences, I would say. The dock band's the one
Yeah.
that's more open on the top. The star band tends to be a little bit more closed on the top. There are multiple helmets offered by both of them, and
Yeah.
Starband does have a 3D printed one now that's very, very lightweight.
Wow. And
Very
I think what's
lightweight.
important to add to that, at least here with dock bands, in my experience, is because many insurances will say it is cosmetic, the helmets aren't covered. So now, if we're talking about 2, 3 helmets, that is an immense amount of money that families are putting out. And I most commonly see families that if a second one is needed, or crazy cases when a third one is needed, that they're like, we're done. We literally can't swing it, you know? So I think that is important to understand too, is that where that cosmetic piece also ties into insurance coverage and the cost that some of these families have to take on to, well, have to take on. And so again, having that full picture and being able to make a decision becomes even more important, right? If you're paying $5,000 out of pocket for a helmet, I would want to feel pretty dang sure that it is necessary and it's not just every place you go to is going to say you need a helmet, which I know is another big thing that parents often feel is like, well, if this is what they do, how do I know that we really need one? So I think having someone explain it like you are and really give you the full picture so that you can make a decision that works for your family across the board financially and with your life and with your little one and what they're going through. I think that's so, so important.
I was gonna add something to what you just said. Oftentimes, a second helmet can be required just due to poor compliance. So to translate that
Mm,
for your listeners who are getting a helmet, if you're getting a helmet and you don't want to have to pay for a second one, commit fully. That 23 we've done research on it, that 23 hours a day versus 20 even hours a day, people think, "Oh, it's only 3 hours." That that is a huge factor in how quickly the head shape's going to correct, and if you're not being compliant, you're gonna outgrow your helmet sooner, and that's why that foam is inside the helmet so that the orthotist babies get sick, we know that, right? But usually the helmet's only off for a week or 2. So that foam that's in there is for those extenuating circumstances where the baby couldn't wear the helmet just because they had a high fever and it just wasn't safe to keep the helmet on, right? But if you're choosing to only wear the helmet, 15 hours a day, you're going to prematurely outgrow your helmet. And then, yeah, it is going to be recommended that you get a second helmet because you haven't been able to achieve your goals with the first one. And that's not the fault of the person supplying it to you. It's just
yeah.
honestly, it's just the nature of how quickly these kiddos grow and how, the helmet is made for a dimension of the head at 4 months. And if you're not wearing the helmet, that head's going to grow. And then that helmet's not going to fit in like the 2 areas where we're holding. So all of a
Yeah.
sudden the helmet doesn't fit. And then the second helmet is talked about. And then the second thing I was going to say is that whoever is doing your evaluation, a good orthotist should be able, or occupational therapist should be able in your assessment before you even started therapy, should be able to say to you, it's highly likely that a second helmet's going to be needed because you're severe and you're really, really young. And I know for a fact that I cannot fit all of your baby's growth over the next 3, 4 months into one helmet. So you should
Wow.
be given that heads up, I think. I mean, I
Yeah.
do. I give it to people
Yeah,
so
yeah.
that they
Now,
know.
just to back up a tiny bit, because I we didn't talk about this. Can you kind of explain what exactly is happening with that foam, right? Like when you see a child, where are you putting foam? What is that foam in one spot doing if there's less foam in another spot? Like kind of just in layman's terms, explain what is actually happening inside that helmet with a baby
Yeah,
skull.
for sure. So, and this, I think this alludes to like the passiveness of this device where parents get kind of scared. Oh, it's like actively squishing the baby's head. It's not. It's actually passively changing the shape of your baby's head. So, helmets are built differently, but in general, there's a layer of foam that's very soft, moldable, and grindable for new growth. So, we can remove it as they get bigger. And then there's a hard outer shell. Sometimes the foam has to be over the areas of contact with the head. So a baby who has plagiocephaly might have a slightly bigger forehead here and a slightly larger prominence on the opposite side. So all the helmet is doing, I call it a helmet hug, is just hugging that, saying no more growth allowed to make more plagiocephaly. Let's redirect the growth out this side and out that side. So, in the same way that their sleep surface biased them to grow like that pumpkin you were talking about, right? They were turned to the side. So, the mattress, the force of gravity, biased them not to grow on their flat spot, but more out the sides. The helmet is reversing that circumferentially, so a little bit more effective. But that's what the helmet does. So it creates air pockets, void spaces over the areas of flatness, and it just gently holds the big areas, the areas where we want no more growth to occur, just gently holds them so that that new growth that they're going to go through their natural biological rate of growth. We're not speeding it up. We're not slowing it down. We're just redirecting it the way the mattress or the sleep surface directed it poorly to start out with. So it doesn't hurt, it doesn't cause headaches unless you're really, non-compliant with wearing it.
Yeah.
But, no, it's a very passive device, and, as long as you're going to your checkups and getting, like, little tweaks done to it, because they don't grow perfectly as
Yeah.
planned, so we do tweak the helmet for better fit, but that's how it works.
Yeah. And like a typical course of treatment, what could a parent expect? I know like here typically you'll go back once a week or once every other week and it's usually about 3 months. Is that the same where you are or does it really kind of vary?
It depends on the age of the baby. My super young ones, I'll follow very closely. Once I would say every 2 weeks, I do a 1-week check-in first off just to make sure everybody's comfortable and confident using the device. And then we'll follow them, I would say between 3.5, because some babies will start a bit early, 3.5 to 5 months, maybe every 2 or 3 weeks. And then between 5 and 7, I'll follow every 3 to 4.
Very cool.
I would say a beginner orthotist might wanna increase the frequency a little bit more. They can learn more that way, but I would say that I can kinda predict what they're gonna need, so I kind of build that in. So mine are maybe a bit more, like an extra week compared to
Yeah.
the average recommendation.
Very cool. And so in terms of in conjunction with helmet therapy and even before going the helmet route, I just wanted to touch quickly on what we had talked a little bit about earlier with other options, especially in those younger babies, for treatment of flat spots. So things like physical therapy and, repositioning and all of that sort of stuff. What is kind of what is your gauge of, okay, I'd like you to go try therapy for 4 weeks, 6 weeks, and then if we're not seeing what kind of change, are you then like, okay, it's time, or let's try a different type of therapy? Is that also just going for you based off of mild, moderate, severe sort of thing? Or what's kind of your thoughts on?
So I would say when they come back to reevaluate after doing a different type of therapy or starting physical therapy after 4 to 6 weeks, depending on the age of the baby, what I'm looking for is a decrease in the outcome measures or the severity scale. So whether again we're using that objective scale or the subjective scale, I want to start seeing the head shape improve. So the numbers will come down. The cephalic ratio or the CVAI, those numbers will come down with therapy sometimes. And then on the subjective scale, they might present lower. It's a 1 through 5 scale. So if they're a 4 and they come back a 3, they may still be a helmet candidate at 3, but at least we know they're getting better.
Yeah.
Does that kind of answer or
Absolutely, absolutely. And would you say timeline-wise for parents, if they're really thinking helmets, I know we touched on this a little bit earlier, but really that 0 to 4 months is when you're most likely gonna see some changes through alternative methods, and then approaching age-wise, like 6 months is when it's probably time to really talk helmet, depending on severity.
yeah, so I would say if you're seeing asymmetry, on the front of the face, that would flag me. And this isn't for every baby. This is a blanket statement that's going to help 95% of the cases. But if you're seeing asymmetry of the face, I think that it's appropriate to get an assessment at 4 months of corrected age. Because if your baby was born 3 weeks early, there's a lot of change that can happen. So I would say corrected
Mm,
age. If there's facial asymmetry or it's really severe looking on the back, then you should have your assessment. If there's no facial asymmetry and it looks like just a little bit of flattening on the back, you can probably wait until 5, 6 months to have your first assessment. But I always say to the therapist that I work with, if a parent is really, really nervous or very anxious about it, I'm happy to assess them, you know, and grab some outcome measures for future. Yeah, I
yeah,
don't know how it's set up locally in your community, but most orthotists will do that
yeah.
for the family.
Yeah. And just to really quickly explain, in case anyone is unsure, when you say corrected age, so when a baby is born prematurely, they have an actual age and then they have an adjusted age, which essentially is like giving them credit for the time that they would have been in utero. So let's say a baby was born 4 weeks premature and they are now 3 months old actual age, their adjusted age or corrected age in terms of being premature, we'd really be looking at them as like a 2 month old. And so even when we're thinking about like motor milestones or milestones in general, that is definitely something we're considering. And typically we correct for that prematurity until 2 years old. So we're giving them 2 full years to catch up to their peers based on their adjusted age. Just
Mhm.
as a piece, because I know sometimes that can be confusing, like what does that mean? They're actually this age, and why are you saying they're not? So
Yeah,
it's
and
I didn't
I would
realize that
say
applied to helmets too.
definitely, and I was gonna say probably I was just gonna add it probably even more so. The cranium is growing at around 2 centimeters per month. The circumference is growing two
Wow.
centimeters per month between 2 and 4 months. So three
Wow.
weeks is could be over, it could be a 1.5 centimeter of growth. So I even still correct, if a baby's born 2 weeks early, I will still correct them.
Wow.
I won't call them premature, but I'll just say to the parent, look, like I am taking their exact age because it has a huge impact because there's so much growth that's happening, especially kind of between 3 and 6 months when we're talking about a helmet or we're predicting treatment time or trying to figure out the best time to start in order to mitigate regressions at the end of therapy. Those 2, 3, 4, and more weeks early can play a pretty big role
Yeah.
in predicting that stuff for parents.
Wow. Wow.
Yeah.
And now I know another really common question that I get is about whether there is a time frame, a month, where if there is no flattening present, parents can kind of like it's probably not going to happen.
Yeah.
Do you have an answer that you would feel comfortable saying related to that? I know, again, it's a variable, but I feel like that is such a common question and concern for
Yeah.
parents is like, when can I just take a deep breath and trust that it's okay?
But I think maybe I'm biased, right? Because I only really see the kiddos that are really a lot more flat. I don't think a head shape's gonna get worse or better after 6 months of age. I mean, I have seen a handful that maybe get a little bit better with a really good therapist after 6 months. I had one family that literally held the chin over while they were
Oh my gosh.
sleeping, like, the parent was sleeping, holding the hand. I saw that baby get better, but most parents won't do
Wow.
that.
Yeah.
I don't know,
Wow.
what do you think? I have a feeling.
My thought has always really been that once baby is moving, once they're
Yeah,
rolling, once they're starting to sit, once they're like really that like 4 or 5 month mark has always felt like the window to me where if nothing's there and baby is moving and starting to meet those milestones that really explode around that 3, 4, 5 month mark, that usually you're kind of in the clear
yeah,
because again it's like really that period where they are fully reliant on you and where you put them is where they stay.
yeah.
So that's always been my kind of thought, but I don't have any evidence to support that at
I
all.
w I would I think the key to what you just said, which is really important to highlight, would be If there's nothing there, like there's no residual torticollis, there's no delay in milestones, the baby isn't hypotonic, then there really is nothing to worry about after 4 to 5 months. If that torticollis is still, definitely impacting them, or parents are reporting that they're still sleeping, 90% of the night on their flat spot, then maybe a little bit more. I had one kiddo, no diagnosis, just preferred to sleep on her belly, on her forehead, and it got flat, between 6 and 10 months, and we ended up
Oh my
helmeting her.
gosh.
Yeah, we ended up
Wow.
helmeting her at 10 months, and she wore it till 14 months, and it did make an improvement. But that's a really rare case, right?
Yeah.
Most babies aren't gonna sleep with that forehead down
Yeah.
100% of the time. So I guess
Wow.
what I'm trying to say is it is possible, but very rare.
Yeah, yeah.
Very
Okay.
rare.
So I think what would be helpful to kind of like tie this all together is I know that you have really helpful tips about monitoring head shape if you have concerns, right? So if a child has it, preventative things like taking pictures. I know you talk a lot about asking for that referral early on, taking note of their preferred sleeping positions, feeding positions. Can they only feed on one side? Are they sleeping with their face mashed into the the crib, If you could give parents like just a couple quick tips to say like this is very helpful information for you and also for an orthotist if that's what happens next? What would those be?
Yeah. Yeah, and I think that a good physiotherapist would also ask the same questions and find the information very helpful. I actually have, since we last chatted, I have one more tip to add, so I'll do that. But, if you're questioning your baby's head shape, I always say snap a photo with your camera. It can be, on your cell phone. You want to capture their nose in the picture, bird's eye view. A great photo to take, usually when their hair is wet. So sometimes in the bathtub can be the best time to grab that photo. If you can get their nose and if possible their ears, not every kid you'll be able to do that, but you can. That way you can line them up side by side. Maybe take a photo once per month, always with the hair wet. If your baby has super curly hair, and even if it's wet, then maybe this won't work for you. Side profile can be helpful. Of course, you're going to have pictures of your babies from the front just because that's what we do. We take tons of photos of our babies, but having one that's straight on, that's meant for the purposes of looking for facial asymmetry, either getting better or worse, can be helpful. It does take time to get into pediatric physical therapy for sure. So if there is a preference to one side, I definitely think just asking for that referral. Around in my community, you don't need a physician's referral. You can just call. You just need it for insurance coverage, but you can kind of get started without the referral. I don't know about in your community. Um, and then let's say you get to therapy, or if you finally get in 4 to 6 weeks later, and your concerns are gone, at least you had the opportunity, because 4 to 6 weeks of torticollis management is huge, right? Like,
Absolutely.
it can make a
Absolutely.
big difference, and these head shapes, sometimes they'll round right out if you catch them early enough. So
Yeah.
I would ask for the referral probably earlier rather than later if you have to, and then if you don't need to ask for the referral, just make the call earlier rather than later.
Yeah.
Again, obviously, if you can afford it. And then everybody's gonna wanna know you know, do you find that they tend to sleep always with their chin or their head turned one way? They're gonna wanna know what percentage of the time. Do they feed way better on the left arm or the left breast compared to the right? Just preferences, and if those positions are always the same, then there's probably a tightness somewhere. But the other tip I was gonna add that parents, I think, find helpful is a lot of times they can't see the facial asymmetry that went until I show it to them. So I always say if you can't see if there's facial asymmetry, you can have your baby sitting on your lap. You and your baby look in the mirror. And if you look at your baby's reflection, sometimes you can see it because you're actually seeing their reflection, the reverse of looking at them straight on, right?
Oh, that's a really helpful
So
tip.
parents will go, "Now that I look in the mirror, I can see it," just because 'cause they're so used to
Yeah.
seeing their beautiful baby that's
Totally.
perfect, right? And then the reflection can help. Or you can just take a
Totally.
picture and flip it on your camera, whatever.
Oh, that is so smart. And it's funny that you say that too, because I know so often, especially with torticollis, like if when doing an evaluation, parents will be like, I don't know, I didn't really notice a preference then. I didn't really notice a preference. And so I'll say, take out your phone. Let's take a look back at some 1 month pictures, some 2 month pictures, because so often, like our baby is perfect. We're looking at them and we're not seeing that they happen to be tilted a little bit this way, but when you pull up those pictures, it can be so helpful in being like, maybe this was there the whole time.
Yeah.
So yeah, that's a really helpful tip. Okay. Is there anything else you feel like is important to share or you want parents to hear or anything you feel like we didn't cover that you think is relevant?
I think that it's important that any parent who has a baby with flatness knows that it's not their fault. And, there are some pediatricians in my community that will do a very good job at making them think that it is. And tummy time doesn't fix this always. So
Totally.
just keep that in mind. I'm an orthotist and I have two girls and one of them had some flatness. And,
Yeah,
this is what I do for a living. So if that is
totally.
true, there's always an underlying cause.
Yeah, absolutely. I love that. And I think that is so, so important because I know there is an immense amount of guilt that comes with it. And even for me, similar to what you're saying about one of your little ones needing a helmet, is two of my kids had torticollis. And one of them I most certainly didn't catch until she was like 6 weeks old. And I had to sit and look back at pictures and was like, oh my gosh, this is what I do. But you're your baby is so perfect. They're all you care about is looking at them. And so it's totally normal, even for professionals in that area, to miss something because you just want to be mom and you should just be mom or dad or whoever. So I think that's really, really important to drive home is that so often it is from in utero. And the times that it's not because you did something wrong or playing the blame game on yourself as parents love to do. I think
Yeah. Yeah.
yeah.
Yeah.
Okay. Oh my gosh. Well, thank you so much for this. This was incredible. And tell us one more time where people can find you, and we will put that into the episode notes as well so that people can find their way to you.
Yeah. Well, thank you so much for having me. And you can find me and some parent resource and educational videos on Instagram at Becki at Bloom. My website also has a bunch of information, www.bloomkidsorthotics.com. And I'm hoping to this fall offer a virtual service that will just give a second opinion, right?
Incredible. I love
For I
that.
did that a couple years ago and then I opened my new clinic. So I put it on hold, but it's coming this fall. I'll be offering that service.
I love that. That is so needed. And just to make note as well for listeners, in case you're not seeing the actual in the episode notes, it's BECKI for Becki, not
Yes,
BECKY if you're looking on Instagram.
I know.
But again, I'll put that in there. I love it. I just want to make sure that people aren't looking for you and like, it's not coming up. But seriously, thank you so much. This was so helpful. I hope it's helpful for any parents or caregivers that are out there navigating this. And yeah, we'll catch you next time.
Awesome.
Okay.
Thank you so much, Casey.
Absolutely.